Hi, and welcome back to Psych 300 Brain and Behavior. We're going to be talking about drugs and behavior today, or Chapter 6 in your textbook. So our discussion will build on what we covered in the last two chapters, talking about the neuron and the synapse. And here we'll be trying to investigate or discuss how drugs come in to influence the action of the central nervous system and functionally working at that synapse. Then we'll talk about how we classify drugs and talk about 4 different types of classes of drugs and how their mechanism of action operates. That will give you the basis then to start working on or investigating your specific drug that you want to do your project on, your mechanism of action blog. So after you watch this class, you'll have a better idea of what we mean by mechanism of action. You can select the drug that you want to do your blog based on and start that process. And then what we'll conclude this lecture with will be talking about experience, or how repeated administration of certain drugs can change and can influence how they influence behavior early in exposure to the drug versus after many exposures to the drug, and some of the mechanisms or processes that they could be operating. So let's go ahead and get started. First of all, when we administer a drug, there are several different routes or ways that it can get into the body and have its effect on behavior. And these different routes of administration have different effects. And the best way to kind of think about this in terms of barriers, there are barriers to getting through into the central nervous system. So we can see here we have these different routes of administration. An oral route of administration would be like taking and swallowing a pill. This route of administration has a lot of issues. First, the drug has to diffuse into the stomach lining, and then it has to go into the blood vessels. From the blood vessels, it then has to travel through the circulatory system, and then from the circulatory system, it has to go through the blood-brain barrier, and then it has to then, from the blood-brain barrier, get into the neurons to impact performance. So there are a lot of barriers. So this oral route of administration is good in that most people can take a pill. It's challenging in that there is a lot of limitations of getting the drug into the central nervous system. So the oral route of administration is convenient. It's because it has to go into the stomach. There are acids there, so it may break down quickly, and you may never get the drug in there. So when you're developing these drugs, you have to appreciate all of the barriers for them getting into impacting the function of the nervous system. Topical, it doesn't have to deal with those stomach acids or the processes in the digestive tract. Topical would be as though you were to put an adhesive strip on the skin, and that contains a drug that has to diffuse into the skin through the fatty tissue into the circulatory system and then have its effect from there. So it still has to make it through the blood-brain barrier. And what we'll see is that some drugs are very effective in getting through the blood-brain barrier. Other drugs are less effective in getting through the blood-brain barrier. So topical, you don't have to deal with the gastric juices, the acids, to the drug, but you still have to diffuse through the skin. One of the limitations is certain drugs can cause irritation to the skin, and so that's one limitation. I guess a good example of this would be the nicotine patch that you can wear, so the nicotine can diffuse through your skin and get into the circulatory system and have its effect in the central nervous system. Intramuscular, this is where you're going to inject the drug into the muscles. And so now you've kind of bypassed that need to diffuse across the skin, and you're injecting it directly into the muscles, and therefore there's fewer barriers for that drug to have to get through. But it's going to have to diffuse from the muscle into the circulatory system. From the circulatory system, it still has to go through the blood-brain barrier. So this will have a much longer release pattern than some of the other ones we're going to talk about, because it's in the muscle tissue and has to diffuse. Now, inhalation, such as smoking a cigarette, is another route of administration. Here the nicotine can go directly through the blood supply that are found in the lungs and get in very quickly. One of the other routes of administration that's amazingly fast would be intravenous. This is injecting the drug directly into the circulatory system, such as if you're being prepped for surgery and they need to give you an anesthetic, they'll either do inhalation or they can give you an IV that contains it, and so it has a very quick onset through intravenous. And again, really the only barrier there in intravenous is going to be the blood-brain barrier that's preventing it. Our last route of administration is intracerebral. Intracerebral is where you skip the blood-brain barrier and you're injecting it directly into the brain. One occasion where this occurs is if someone has some type of infection, bacterial infection inside of the central nervous system, and trying to get drugs, antibiotics into the system is difficult. Antibiotics are very difficult to get past the blood-brain barrier, and so on rare occasions where they think it may be helpful, they'll do direct intracerebral injections of antibiotics to try to treat an infection. So there is an example of where the blood-brain barrier is causing a problem, although it does a lot of help. It protects and keeps a lot of dangerous kinds of things out of the central nervous system. There we're trying to treat the infection, and we'll need to use a antibiotic injected directly into the brain. We're skipping the blood-brain barrier. Now, these different routes of administration have different effects on the time frame or the way the drug will actually come in and increase in the central nervous system. And what we can do in this graph is look at plasma level concentrations of, let's say, cocaine. So if you were to inject cocaine directly into the veins or intravenously, we'd see by 60 minutes we'd have a high concentration from what we see at zero prior to the injection of cocaine within the central nervous system, and it very quickly kind of tapers off. But what about if we use those other routes of administration where there are more barriers where it has to diffuse through? So intranasal inhalation there, where it has to diffuse into the circulatory system, we see that we don't get that immediate increase in plasma levels, but it remains fairly stable. It remains fairly constant, and there isn't that very quick drop-off. So the way the drug unfolds through time, the levels can vary depending on the route of administration. Now, oral, ingesting cocaine orally, we see that that is going to translate into a much lower peak initially, and then it'll gradually increase and then decrease over time, so that we're not having as much cocaine with that oral route of administration that we would have with intranasal or intravenous. And we see the temporal characteristics, or how the drug can impact the central nervous system, varies depending on the route of administration. And we'll come back to this idea that a route of administration can actually be a useful tool in treating drug addiction and understanding drug addiction processes. But here, this is just illustrating what happened. What would it look like, the blood levels, if we injected someone directly with cocaine intravenously, or give them intranasal exposure, or oral exposure to cocaine? And we can see that you can get a very quick increase in cocaine if we do IV, but then that is eliminated fairly quickly, whereas these other routes of administration where there are more barriers, you don't get that immediate increase, but they tend to be more protracted, or their levels continue for a longer time frame. So let's talk about another aspect of the blood-brain barrier, and what we see is that it's not always so present across the entire central nervous system. There are actually 3 places in the central nervous system where there's a weakness, or there's a limitation, or the blood-brain barrier isn't as effective in getting, preventing chemicals from getting into the central nervous system. The first area that we see where there's a limitation or a weakness in the blood-brain barrier is the pituitary gland, as we can see here. And if you remember our discussion of the neuroanatomy, the pituitary gland is on the midline, and it's involved in, and it's just below the hypothalamus. It's involved in, so here's the pituitary, here's the hypothalamus. It's involved in regulating a number of hormones throughout the central nervous system. So we can see that part of that activation of the different kinds of regulatory behaviors depend on the pituitary, and it needs to have access to the circulatory system to release certain types of hormones into the system. So that makes sense that we don't want a strong blood-brain barrier there. The pineal gland is responsive to the effects of certain chemicals that change across the course of the day. And in our last chapter, when we're talking about sleep, we'll see that melatonin levels can increase and decrease, and they have their effects on our sleep wake cycle, and they need to have a nice access to the circulatory system, and those compounds don't readily move through the blood-brain barrier, so by weakening it there in the pineal gland, we can allow them to have access and influence our circadian rhythm, or how we wake up at a certain time of day and go to sleep at a certain time of day. Allows access there. Now there's one last place that has a weakened blood-brain barrier, and that is the area postrema. And if toxic substances or substances that pass through there start to activate that area, what's interesting is that it induces vomiting. So it's kind of like a safety switch, that if you're eating something that is able to pass through there that is going to be toxic, what happens is you start to throw up. And so it's a little bit of a safety protection mechanism trying to get those toxins out of the system, and it's a first line of defense against that. So just having a weakness right there, that means some of those chemicals can start to get in, and if you start throwing up, you can eliminate, or vomiting, you can eliminate that chemical from the system and prevent further damage to the body and the brain. Now, once the drug gets through the blood-brain barrier or starts to influence the brain, we see that it can function in 2 ways. Either it can function as an agonist, and the definition of an agonist is any drug that increases the effectiveness of neurotransmission. Now this seems like a pretty straightforward definition, and on the surface it is, that we're increasing the function of the drug, or the drug is increasing the effectiveness of neurotransmission. We'll see that that can have an amazing variety, or a great deal of effects on behavior. So you see an agonist, you might think right now, based on that definition, oh, that's all the good drugs are agonists because they increase neurotransmission. We'll see that some drugs that are used therapeutically are agonists, but other drugs could be poisonous or agonists. So we'll see that there's a whole range of drugs that function by increasing neurotransmission, or would be considered agonists. The other class of drugs are antagonists. And that's a drug that decreases the effectiveness of neurotransmission. They prevent, hamper, interfere with, attenuate neurotransmission. That's an antagonist. And what we'll see is they can work at many different points in those stages of neurotransmission we talked about last chapter in the synapse, or communication across the synapse. So we can see that within synthesis, we can have drugs that either serve as a precursor, so they would be an agonist, or drugs that inhibit the synthesis of neurotransmission. So those would be an example of an agonist or antagonist at the synthesis phase of neurotransmission. So an agonist would help or facilitate neurotransmission production, synthesis of a neurotransmitter. And we'll give you specific examples of these after we go through all these different stages. Now remember, we have to store the neurotransmitters, and a drug that interferes with that storage would be an antagonist. So a drug that would inhibit or cause these vesicles here to become leaky, which there are drugs that do this. They cause the vesicles to be leaky. The neurotransmitter leaks out, and then it's broken down by enzymes within this area, the presynaptic membrane here of this neuron. If it becomes leaky, then they break down, and now that neurotransmitter is no longer going to be able to have its effect. That would be an example of an antagonist, something that prevents the storage. Now release. We have drugs that function to either help the release of the neurotransmitter, facilitating neurotransmission, and be considered an antagonist. We also have drugs that prevent the release of neurotransmission, where they slow down, so now the neurotransmitter is not going to be released as effectively, and those would be considered antagonists. So release is another stage of neurotransmission where a drug can either facilitate, improve, enhance, and act as an agonist, or a drug could attenuate, hamper, prevent release, and act as an antagonist. Now, at the receptor interaction, this is where there's a variety of ways that drugs can have an effect. What we can see is that we have both agonists and antagonists that function at the receptor, but they can be a little bit more complex in that there can be, as you see in this picture, several binding sites, places where the neurotransmitter can bind here or here. So if a drug binds and it facilitates receptor action, it's an agonist. If it binds and prevents the function of that channel, it's an antagonist. So activating that and causing that channel to function better or more than normal would be an agonist. Binding and preventing that action would be an antagonist. And we'll talk more about those when we get into our specific examples in terms of that. But know that we can have this effect. Drugs can impact the function of receptors in either helping those receptors work better or actually functioning like the neurotransmitter itself, or it can prevent the neurotransmitter from binding to that location. A drug that facilitates binding is an agonist, or helps binding is an agonist, whereas a drug that prevents binding or prevents the action on the channel is an antagonist. Now, inactivation is another way in terms of this, and this could be as simple as preventing the enzymes that are present in the synaptic cleft from working. So if an enzyme that normally breaks down that neurotransmitter is inactivated, that would be an agonist, because you would essentially have more neurotransmitter than you normally would in the synaptic cleft. So here we see giving a drug that prevents those enzymes from breaking down the drugs, essentially increase the amount of that neurotransmitter and then increase neurotransmission. It would be functioning as an agonist. And reuptake, another way that we inactivate the drugs, is where the the neurotransmitter is normally reabsorbed presynaptically, there are drugs that prevent that reabsorption or reuptake, and those that would provide a situation where there would be more neurotransmitter in the synaptic cleft, and that would enhance neurotransmission. So anything that prevents reuptake would be a agonist. They would be helping that in that regard. And then finally, you can have drugs that influence the breakdown of the neurotransmitter within the presynaptic membrane or the neuron there, and those drugs would, if you interfere with the degradation or the breakdown of that, would essentially increase the amount of that neurotransmitter available to be released, and that would also serve as an agonist. So we can see agonists and antagonists can have their impacts in these very different stages of neurotransmission, from the synthesis to the storage to the release, receptor activation, inactivating the drug in the synapse by turning off these enzymes or preventing reuptake, or even within the reabsorbed neurotransmitter, what we'll see is that these drugs or these neurotransmitters can increase or decrease neurotransmission, depending on where they're at in their effects. So there's a lot of places that pharmaceutical companies can look to try to enhance or prevent neurotransmission to alleviate disorders like depression or anxiety or schizophrenia. And so that's what we'll see as we start to move through our examples where researchers have tried to use these different points of neurotransmission. So we talked about this at a very general level. Let's go in and talk about the specifics and give you some example drugs of how they can function as an agonist or antagonist in these different stages of neurotransmission. First, a good example is acetylcholine. Now, you might recall from our last chapter we talked about the discovery. Acetylcholine was the first neurotransmitter that was discovered by Otto Loewy, and a lot of work has been done since, and what we find is that you can increase levels of acetylcholine, which is a neurotransmitter that's important for learning, memory, movement, so it's widely used throughout the central nervous system. We'll see when we talk about this later that it's also important for memory. Specifically, we'll talk about Alzheimer's disease. But we can increase the amount of acetylcholine by having a diet rich in some of those precursor chemicals. So by increasing, for example, olive oil or egg yolks, we can increase the amount of acetylcholine precursors, and if there's more of those available, that means a choline-rich diet increases the level of acetylcholine to go around. And so that diet would essentially serve as an agonist. So again, synthesis, providing from your diet more of the basic building blocks that build that, would function as a agonist. Now, what we can see is that there are certain drugs or compounds that actually can cause the release of or influence the release of acetylcholine. One of them is black widow spider venom, and you can imagine that if black widow spider venom causes the release of acetylcholine, it's going to be an agonist. And what you would expect to happen is if you're releasing, you're facilitating, you're enhancing neurotransmission with that much more than you expected, you might expect, given Otto Loewy's experiment, that your heart rate would slow down. You might also expect, because remember, acetylcholine has that different effect on skeletal muscles than cardiac muscles, that it actually causes a paralysis, a rigid paralysis. So all these muscles start to contract. So if you're bitten by a black widow spider or an insect, what happens is the respiration, the heart actually starts to slow down and then all the muscles become rigid, that's a very efficient tool for capturing your prey. They're paralyzed and the heart starts to slow down, and it's a very adaptive tool, or a good tool to actually catch your prey. So black widow spider venom is an example of a acetylcholine agonist that functions to promote the release of acetylcholine at the synapse. So that's what it does. It starts dumping a bunch of acetylcholine into the synapse, and it's going to do it wherever black widow spider venom is applied. If it's on cardiac tissue, that means you're going to slow down the heart rate, and if it's applied to muscle tissue, the muscles on both sides of the arm will start to contract, and you'll get this paralysis, but it'll be a rigid paralysis where the arm isn't able to move either direction because both muscles on either side of the arm are contracting very strong. Now, botulinum toxin, or Botox, that makes up Botox, works in the opposite direction. It prevents the release of acetylcholine at the synapse. And so this will actually cause muscles to relax. If you're not releasing botulinum, or you're not releasing acetylcholine, or you're preventing the release of acetylcholine, now there's the synapse that's going unused. And if you inject this to certain parts of the body, you can actually take and cause the muscles to relax. There are certain neurological conditions, such as spasmodic torticollis, where you have muscles that are spontaneously contracting because of these motor neurons are firing in a random fashion. And so originally botulinum toxin was developed to treat that spasmodic torticollis. But people realized that it could also be used for cosmetic purposes and injected into areas where wrinkles are occurring because these muscles are contracting. But this is an example of acetylcholine antagonist, and it prevents the release of acetylcholine, and you can see that it's going to have very different effects depending on where it's applied. And it's been used to treat neurological disorders where these motor neurons are firing too quickly, or cosmetic reasons where there may be more muscle contraction than what someone likes and causes wrinkles. So that's release. We've talked about synthesis. We've talked about release. We can talk about receptor action. And two good examples of both an agonist and an antagonist are nicotine and curare. That means that when we, if we were to smoke a cigarette or chew some tobacco, ingest nicotine in some fashion, wear a nicotine patch using that different route of administration, what's going to happen is that it's going to bind to those acetylcholine receptors and function much like acetylcholine would in that receptor and having its effect on the channel. Now, in the peripheral nervous system, that may involve increased muscle tone, but in the central nervous system, that means you're going to change the communication or enhance the neurotransmission in the central nervous system. So smoking, there's nicotine in there, and that's going to enhance communication in the cholinergic acetylcholine-based neurotransmission. That often translates into increased attention, increased memory, but of course smoking itself has a lot of other terrible side effects, such as cancer is a big one. So engaging with this, while it may have some enhancing properties, it also has some significant challenges or bad side effects. Now, curare, on the other hand, is acetylcholine antagonist. So what it does is it binds and prevents. It actually binds to the acetylcholine receptor and prevents that from actually functioning. So it kind of turns off acetylcholine. So you can imagine that you'll see, with your curare, curare has been used, was discovered as a chemical because it was used to hunt. Certain tribes in Africa would coat the tips of their darts, as you can see here with curare, and they would then apply, use these darts and inject, use them to catch prey. So if you would introduce curare or was able to hit your prey, what would happen is that the muscles would all relax and the heart rate would start to speed. Just that kind of the opposite effect of what we see with black widow spider venom. So curare is binding to the acetylcholine receptor, but preventing any kind of function of that. So they would be considered an antagonist. So you want to keep that in mind, that curare would be a good antagonist in terms of paralyzing the muscles by keeping the heart running faster, when we talk about another drug here in a little bit. So our next type of drug that effect we can talk about is an activation within the acetylcholine system. And acetylcholine esterase is very important for breaking down acetylcholine in the synapse. And that is an enzyme. And what we found is that within these enzymes, we can actually influence or change their function. And so with acetylcholine esterase, we can permanently turn that off with a compound known as sarin, or nerve gas. Sarin is the name of this type of organophosphate that will permanently shut off acetylcholine esterase in the synaptic cleft. And if you do that, what happens is that acetylcholine will continue to be released, but it's never broken down. It may diffuse away a little bit, but it just builds up. You're flooding the synapse. And so what you'll see in that situation is that the heart will start to slow down, and all these muscles will become very rigid, much like what you see with black widow spider venom, causing the release of this. But because you don't have any acetylcholine esterase working to remove it, you're just flooding that synapse. And what we see is that that's used in those nerve gas agents like sarin. Now, this is really a spectrum here. So on the one end, we have sarin that permanently inactivates acetylcholine esterase, this enzyme that breaks down acetylcholine. On the other end of these organophosphates that block inactivation, you have Aricept. Aricept is a drug used to treat Alzheimer's disease, and it momentarily binds or inactivates acetylcholine, so that although there's a reduction in acetylcholine in Alzheimer's disease that translates to these memory problems, we can momentarily increase acetylcholine, not to the level where you're going to see those rigid paralysis or the speeding, the change in the heart rate, or slowing down of the heart rate, like you would with the sarin gas, because you're showing this increase in acetylcholine. But what you see with Aricept is it's just able to temporarily increase the amount of acetylcholine so that you're able to maybe reignite some of that neurotransmission that's stopped or stalled in these individuals with Alzheimer's disease. So on one end you have sarin gas that permanently turns off or eliminates acetylcholine esterase from the synapse, causing death in these individuals. On the other end, you have Aricept, which can be used to treat Alzheimer's disease. It's not 100% effective, and it does help sometimes with people, but it's definitely not a cure for a lot of the process that's going on. Now, I kind of laid out a couple of breadcrumbs here. Let's say that you have immediate response team, and somebody is being, as we can see here, impacted by sarin gas. Is there a drug or a compound that you might want to use to combat that sarin gas until it can be eliminated from the system that we've already talked about? What would be one drug that might be effective in that? Well, look through your notes. If we look back, maybe you would say curare, and curare would be good because maybe with curare, what you could do is temporarily give that, block acetylcholine's effect on those receptors, and then allow for some of that sarin to be removed, and you could potentially intervene and prevent that effect. So you can start to see that you could use these in combination to have different effects. So moving to a different neurotransmitter system that we'll talk about, dopamine is nice because there's a variety of ways in which we can change, either have dopamine agonists or antagonists. L-DOPA is a drug that we spoke about that's often given to people with Parkinson's disease. Remember, with Parkinson's disease, you have a degeneration of the substantia nigra, and those are dopaminergic-rich neurons that project up to the basal ganglia. And by giving L-DOPA, you can increase the amount of dopamine available. And what we've seen is that that can have temporary effects of alleviating some of those symptoms associated with Parkinson's disease. So L-DOPA would be an agonist. It's helping in the synthesis, or that biochemical pathway in the synthesis of dopamine. Now, in terms of reuptake, both cocaine and amphetamine can prevent reuptake of the dopamine. So if dopamine is not being reabsorbed presynaptically or into the releasing neuron, that means there's more dopamine to go around and more binding. And you can now have that increased amount of dopamine available to bind and enhance neurotransmission. What we find is that dopamine is located in both these motor systems, like we see with damage in Parkinson's disease, but it's also involved in the reward systems. And so when you're eating that delicious chocolate bar, or you have a really good meal and there's pleasurable characteristics, we're activating dopaminergic systems, and cocaine and amphetamine are functioning to increase neurotransmission by preventing dopamine from being reabsorbed. Interestingly enough, we see that amphetamine also causes the release, the presynaptic release of dopamine. So amphetamine will actually cause the dopamine transmitters to run in reverse, causing dopamine to be actively released from the presynaptic membrane. So amphetamine is doing a lot in terms of aiding neurotransmission, and it's a strong agonist of the dopaminergic system, increasing neurotransmission. Now, at the receptor level, we can see that chlorpromazine, which is a drug used to treat schizophrenia, can block a dopamine site and actually prevent it from having an effect. And so what we can see is that you have different sites on here. So we'll say a D2 receptor, indicating it's a site on this here, a dopamine receptor site, and then chlorpromazine is available. It will block dopamine transmission. So what we see is that chlorpromazine has been used to treat schizophrenia in terms of blocking the dopamine neurotransmission and the role of dopamine maybe in some of those symptoms associated with schizophrenia. So that's really a lot of the ways in which drugs can impact neurotransmission. We gave some examples there. Now what we want to do is give you different classes of drugs. And there's a lot of ways that we could potentially classify drugs. Right, we could try to go in and classify them based on their mechanism of action, how they influence neurotransmission, where these all drugs influence receptor activation and inactivation. These all impact the synthesis. These impact the release. But because drugs can have so many different effects in neurotransmission and have the same effect on behavior, or you can see that two drugs could be functioning in a very similar way but change behavior dramatically, we tend to classify drugs based on their net effect on behavior, not their mechanism of action. But it's important to understand their mechanism of action to try to understand and explain why they influence behavior in the way that they do. So our classification system we'll talk about here 4 different types of drugs, classes of drugs, and give you examples of each one, talk about these drugs' mechanism of action, and some potential side effects associated with them. First, we'll talk about anti-anxiety agents and sedative hypnotics. We'll talk about their what they're used for and what's their mechanism of action and some effects that they have. Then we'll talk about antipsychotic agents. Then we'll talk about antipsychotic agents are used to treat, for example, schizophrenia. Then we'll talk about antidepressants and what their mechanism of action is. And then we'll talk about opioid, or drugs that are used, analgesics used to reduce pain. So with our classification system, we can see that even within these anti-anxiety or sedative hypnotics, we have several different examples. For example, with sedatives, we see alcohol is a good example of that, and barbiturates are a good example of that. Whereas anxiolytics, we have Valium, which is an example of a drug that functions to reduce anxiety. So we have sedatives and anxiolytics, or agents that function to reduce anxiety, and Valium's an example. And we can use them to either momentarily sedate people who are in extremely aroused or stressed condition. Can be used to prescribe barbiturates, or drugs can be prescribed for people that suffer from anxiety, severe anxiety, and trying to reduce them, their experiencing that anxiety. So what is their mechanism of action? And this is really important. What we see is that these anti-anxiety agents and sedative hypnotics are functioning through the GABAergic neurotransmitter system. So GABA is a neurotransmitter, and it is a major inhibitory neurotransmitter in the central nervous system. So what happens is you have a GABA receptor, and it's associated with this channel, and what we see is that once this channel opens up, chloride, we talked about those ions before, remember sodium chloride is the highest concentration outside of the central nervous system. And we didn't really go into much detail about those chloride ions, but those chloride ions are negatively charged, and we have chloride channels in the central nervous system, and GABA, when it binds, what happens is GABA binds and it'll allow chloride ions to flow in that are negatively charged, and they will inhibit action potentials, basically shutting down the central nervous system. So they can turn off the nervous system if GABA binds. Now, sedative hypnotics, so there's a place where a GABA neurotransmitter will bind, and it will prevent the neuron from firing by allowing chloride to flow into the neuron and producing these IPSBs, or basically shutting down the neuron. Well, the sedative hypnotic site, as we can see here, is where alcohol or barbiturates bind, and they can also completely turn off they can turn off or function just like GABA, where they'll prevent an action potential from firing. So they by themselves, taking alcohol or barbiturates, can turn off those neurons. Now, there's another site at the GABA receptor here where benzodiazepines or drugs that function to reduce anxiety can bind. Now, what's interesting is that these benzodiazepines depend on GABA being available. So here, what we have is GABA has to be present for benzodiazepines to have an effect. These are called indirect agonists. So while alcohol or barbiturates are direct agonists in that they can all on their own function to cause this channel, benzodiazepines basically help GABA. So they're indirect agonists in terms of helping GABA to have its effect here. So they might do something where they cause GABA to stay bound a little bit longer. Now here's what's important to take away from this class of drugs here, is that if you were taking something, a benzodiazepine, for an anxiety disorder, and then you start to drink alcohol, what's going to happen is you're going to have all three of these, and GABA is present. So benzodiazepines keeping GABA present, and then you're drinking alcohol. That means that you can completely shut down this system for much longer than what should be. And this combination of alcohol with those benzodiazepines are often deadly. People easily overdose. And you hear about this in the media of people that are taking anti-anxiety agents and they start drinking alcohol, and the combination of both of these are deadly. So you don't want to combine these two agents together. This is very, very dangerous to keep in mind. We see that there are also some other complications from this class of drugs. First and foremost is alcohol consumed while someone is pregnant can have very damaging effects on the development of the fetus. And so you can see that if someone does drink when they're pregnant, they will develop fetal alcohol syndrome. This has a range where you can have minor effects to very significant effects of this. So alcohol changes the developmental trajectory of the fetus. Consuming alcohol is going to impact that development of that individual. Tolerance, so what we see is that if you take a drug in this class one time, you'll have a certain effect, but if you continue to take that effect or consume that drug over a long term, you're going to have to consume more of that drug to get that same original effect. So maybe you've had this experience where the first time that you drank alcohol, you felt that effect very quickly, and then after a couple of times drinking or so, you see that it took more alcohol to get the same effect. So you've built that tolerance. What's interesting to note about this within this group is that you can get cross-tolerance. So that, for example, you drink a lot of alcohol and you build your tolerance, that's going to have its effect here and change the functioning of the GABAergic system and its firing, so that now benzodiazepines or these other agents may be less effective. So you can see cross-tolerance from drugs in this category of the anti-anxiety agents as well as the sedative hypnotics. Another issue that we've talked about is potential coma and death by combining these drugs together, and both these drugs, agents, have the potential for being abused, highly abused potential. So that's another complication associated with this class of drugs. So in terms of our next class of drugs, we'll talk a little bit about antipsychotics agents, or drugs that are functioning we'll talk about their mechanisms of action. They were really developed very early on. We found that these drugs were very effective in treating individuals that had schizophrenia. And what we find is that there is this gradual, from 1946 to 1955, a gradual increase in the number of patients that were being admitted into mental institutions. And then the development of these drugs, we see there is a dramatic decline in their residency here until when we get out to 1970 and all the way through 2000, that there's a dramatic decrease. And that is largely due to the effectiveness of these drugs to influence neurotransmission, or at least attenuate neurotransmission in the dopaminergic system to treat schizophrenia. Now, what we talked about and just previously is that they function at the dopamine receptor. These antipsychotic agents work to prevent neurotransmission by blocking that dopamine receptor. One of the significant complications we see with these drugs is that these people will develop Parkinson's type of movement disorders or dyskinesias. That means there's a disorganization of movement that we see with them. We also see, on the other hand, people that take these kinds of dopamine agonists start to show some symptoms associated with schizophrenia, such as some hallucinations. So what we see with these mechanisms of action, just a second, let me sorry about that. So we're back here talking about these antipsychotic agents and talking about their mechanism of action, and that they influence function at the dopamine receptor. They basically are dopamine antagonists. And one of the things is, because you're blocking dopamine at this receptor, you're going to see some of the symptoms you see associated with Parkinson's disease. Because remember, Parkinson's disease, you see problems with neurotransmission. There isn't enough dopamine. So by blocking this, people with schizophrenia will often start to show some of those movement problems, problems initiating movement, problems in tremors, those kinds of components. With that, we see if we ramp up or we have too much neurotransmission within the dopamine system, is when we start to give high doses of amphetamine or cocaine, we can see that they start to exhibit some of the paranoia and other symptoms associated with schizophrenia, some of the hallucinations. So we can see that this system is somehow related to dopamine, both schizophrenia or these kinds of disorders. Our next class of drugs we'll talk about are antidepressants. And examples of those are Prozac, Zoloft, and Paxil, or fluoxetine. These are used to treat major depression for individuals, and they've started to be used to treat obsessive-compulsive disorder. So major depression we see is defined as prolonged feelings of guilt or worthlessness, frequent thoughts of suicide or suicide thoughts. And in terms of prevalence, we see that it's around 6% in the population have this at some point. Obsessive-compulsive disorder, this again is a major problem with daily living due to obsessive thoughts, such as ideas you can't get out of your head, whether you're concerned about certain germs or leaving certain things on in the house, such as the oven, other kinds of thoughts. These are ideas you can't get out of your head. those obsessive thoughts that will then translate to compulsive kinds of actions, such as in order to deal with these thoughts about germs, you'll start to wash your hands excessively, or that compulsion to have to wash your hands much more excessively, or do certain kinds of ritualistic behaviors to know that something has happened, those kinds of checking behaviors. So both of these disorders have been used. These antidepressants have been used to treat both of these disorders. So what are their mechanisms of action, or how do they change or influence neurotransmission? Well, we see that there are two generations of antidepressants. Our early first-generation antidepressants were called MAO inhibitors. MAO inhibitors inhibit or prevent the breakdown of serotonin within the neuron. So what we see is that there's this MAO, monoamine oxidase, that normally breaks down serotonin. So what happens is you can give an MAO inhibitor that prevents the breakdown of serotonin, results in a net increase in serotonin available to be bound, to be released, and that is an agonist. So MAO inhibitors were initially found to be very effective in treating some of these symptoms. One of the important complications with MAO inhibitors is that they can be absolutely lethal when combined with certain foods. So a certain food, if you eat it and you're on these MAO inhibitors, will kill you. And that is something that you don't want to give to someone, that knowledge, when they have these thoughts of suicide. Especially because some of these drugs, these antidepressants, often take several weeks, 2 to 3 weeks, before they start to become effective. They're on board, they're immediately having an impact on the neurotransmission, but they don't start working until 2 to 3 weeks after you've been taking the drug. So again, MAO inhibitors function to inhibit monoamine oxidase breaking down serotonin. So if you have more serotonin go around, you're enhancing that serotonin neurotransmission. SSRIs are the next generation that we don't have those lethal combinations with certain food items. Basically, SSRIs are selective serotonin reuptake inhibitors. So they're preventing serotonin from being reabsorbed presynaptically. That means now there's more serotonin available in the synapse, and they can bind more and have its effect postsynaptically. So those are another way that we can enhance neurotransmission within the serotonergic system. So one of the interesting things about these drugs that are used to treat antidepressants, specifically MAO inhibitors and really SSRIs, is that they take 2 to 3 weeks to have their effect, but they are immediately enhancing neurotransmission. And it's led people to try to find, well, what's going on there? So we're enhancing serotonin immediately. Why aren't the moods immediately getting better? And one of the things that's recently been observed is that these SSRIs are associated with the increase in new neurons, specifically in the hippocampus. And so some people have become really interested in understanding, and that increase in those new neurons takes place within about 2 weeks, wondering whether or not maybe those new neurons are part of the mechanism of action for these SSRIs. But more work is going on. This is very early discovering this, trying to see why behavior symptoms improve are so lagged from the mechanism of action, and neurotransmission is so quick. And maybe that link of new neurons is being an important role. So our last group of drugs that we'll talk about narcotic analgesics are morphine and heroin, and they're used to induce sleep or reduce pain. Really, morphine is one of the most effective pain relievers that a physician has. It is just more effective in reducing pain, and it's acting there in those endogenous opioid receptor sites that we talked about in the periaqueductal gray matter. It's acting in other areas, but it's functioning to shut down those pain signals. So it's a very effective pain reliever. Heroin is better able, so it's like morphine, that's amazing in reducing pain, but it's more soluble in fats. So heroin is able to cross through those phospholipid bilayers and get through the blood-brain barrier quicker than morphine is. So when you think about mechanisms or those routes of administration, heroin is going to zoom through there, whereas morphine is going to be take a little bit more time. It can still get through, but heroin is going to be more soluble and get to the brain quicker. The site of action, again, is at those endogenous opioid receptors that we were talking about. Certain kinds of complications is that as you increase that dose of these narcotic analgesics, as you're going to suppress respiration. So increasing those doses, you just start to turn off and suppress respiration. They also have a high abuse potential. So they're very, very, very highly abused drugs. So, for example, there's a recent change in, over generations, there's a change in drugs that are preferred, from stimulants like amphetamines to narcotics such as morphine or heroin, and now OxyContin is also a part of that group that's highly abused potential. So let's turn now to how experience with a drug can change its effectiveness. And we talked a little bit about this idea that drugs can lose their effectiveness over time, and that's referred to as tolerance, or a drug decreases its effectiveness over many administrations. And your book talks about, and I like to bring it up here and highlight it for a couple of reasons. First, this basic brain behavior that drugs can change their effectiveness, and we have good evidence of that. Your book talks about a study with people exposed to alcohol, and these were prisoners that were able to elect to participate in the study, where they were given free access to as much alcohol as they wanted, and they were then monitored for their blood alcohol content, as well as monitored for the behavioral level of intoxication that they had. And so for these individuals, and I forget the exact page that this graph comes from, but the study was done by Isabel and others in 1955, and what they did is they looked at how much alcohol they were consuming across 20 days. So they were given as much alcohol as they would want a day for 13 weeks, and then they monitored how much alcohol they consumed, and they looked at the blood alcohol level across those days. And what you notice is that although the alcohol level intake increased across days, the blood alcohol content showed a very different function. Here it increased with the increasing amount of alcohol, but at some point at around 10 days here, we see it starts to level off, and then the amount of alcohol in the blood actually decreases. And we see that there's a change and where there's actually a reduction. So the body is changing in response to that alcohol level, and we see that that average degree of intoxication also changed. And we see that that decreased with that. And it follows a slightly different time frame here than what we see with that. So there's a dissociation not only from the amount of the drug that's being consumed, but the impact on the body. There's the level of the blood and the alcohol, and there's a change in its effect on behavior or level of intoxication that's distinct here. So tolerance appears to be a very complex process that involves the body but also the brain. And so I think the study kind of demonstrates that. And now obviously there are a number of potential factors that could contribute to this. Changes in the liver, the way the liver could metabolize that and prevent that blood from staining the alcohol or the drug stain in the central nervous system. There's obviously changes in the neurons that could be occurring where maybe there's formation of additional receptors, or you're depleting certain neurotransmitters. Those kinds of things could be happening. But what I want to argue, and this is where we kind of change the pacing a little bit of the presentation here, is I want to argue that there's evidence that learning, basic learning phenomenon, could also be influencing the development of tolerance. Now, I don't mean to have you think that that doesn't mean there aren't changes in the brain. We see clearly, our previous chapter ended with discussion of how synapses change to support memory, and learning is a foundation for memory. So there's obviously got to be changes in the central nervous system that are supporting that. So I don't want you to think that this learning somehow doesn't depend on changes at the synapse. But we want to look at a certain type of learning process, and we'll talk about this as classical conditioning. And that classical conditioning may be contributing to some of this tolerance that we're seeing here. We won't use alcohol in our example, but there may be something that's going on where the body's learning to prepare for that drug administration. And so it's ready to fend that off. And we think that maybe some learning process is contributing to that, and that's classical conditioning. Now, everybody should be familiar with classical conditioning from Intro to Psychology, other classes that you might have taken. But what I want to do here is review that a little bit to talk about those different features of classical conditioning. So, with classical conditioning, you remember you have an unconditioned stimulus that's food. So, an unconditioned stimulus would be food. That means under all conditions, it doesn't matter, you give a dog food and it's going to drool. So if you give a dog a little bit of food, you're going to see that it drools. That's very consistent. It's a reflex that happens. The food is going to be ingested. You need to prepare the body for that oncoming food that you're going to have to digest, so you increase the saliva. So this is, the drooling is the unconditioned response. So you present an unconditioned stimulus, which is food, and you get this response right after presenting the food, or the drooling of the dog. So those are two components here for classical conditioning. Hopefully this is familiar for folks. Now, what happens if you start pairing a sound with a food? So if we give, for example, some sound, so every time that we go to give the food, we run a can opener or something like that, or we go into a drawer to take out some kind of object to open up, such as a can opener. So these are all sounds that are actually paired with the delivery of food. That tone or that environmental stimulus is referred to as a conditioned stimulus, or a CS. Remember, the food is the US, and if we repeatedly give that sound, whether it's a can opener, electronic can opener, or going into a silverware drawer to take out a metal can opener, those are sounds that start to always predict that you're going to get food. And so what we see is multiple pairing of the CS and US, and because you're giving the US, you always get the unconditioned response, or the UR. What's going to happen is if you present the CS one time by itself, so you go into the kitchen, you take and get the electric can opener going, your dog's going to come over and start to drool or think that it's going to get food. So there are great examples of this on the internet of classical conditioning. You might want to go onto YouTube and do a search, which we could do right now. I think I'll try this. It's always a little scary when you go to YouTube to see what is going to come up when I put this. But let's see what happens. And I'll put YouTube in here and put classical conditioning. Yeah, sorry, that just closed out. What I'll do is I'll pause this. All right, we're back. I found the clip I was looking for. Let's see if it works here. And it's a little bit low. I can't hear it. I always laugh when I see that. So again, you might want to search YouTube. You may want to try to search YouTube for classical conditioning, The Office, to get a better audio version of that than what we have here. But it kind of illustrates that. It illustrates that effect of classical conditioning, where you're pairing CS with the US. In that situation, the CS, the conditioned stimulus, was the noise on the Jim's computer, and the US was that altoid, or that breath mint. And what you see is that he continued to pair them, so that then he gave, on one trial, the CS by itself the tone, and you saw that Dwight had that response of mouth being dry and asking for another altoid. So the question is, can we apply this? Can this idea of classical conditioning and learning about events, stimuli in our environment to explain some of the phenomenon we see with tolerance, and specifically drug tolerance? And so to do that, here is what the stimuli would be. So the unconditioned stimulus would be morphine. The unconditioned stimulus would be morphine, much like food is an unconditioned stimulus. Now the unconditioned response that morphine elicits is analgesia, or reduced pain sensitivity. So you're not going to be as sensitive to pain after receiving morphine, and just like with if you were to give food, you would see drooling, you give morphine, you see analgesia. So the unconditioned stimulus is morphine, the unconditioned response is analgesia. Now, what would be a possible conditioned stimulus? Dwight used that tone. We used a tone with our dogs talking about that. Well, we could use environmental cues. cues in the environment, such as what our bedroom looks like, or what a bathroom looks like, or a club. These are all possible environmental cues that are available to use when a drug is being administered. So we compare, if we were to give morphine in the exact same environment over several days, we might see the development of a compensatory response that negates or prevents morphine's effect on the body, just like we saw with alcohol and what we also see with morphine tolerance. So morphine tolerance occurs over days. The first time you take morphine, you see that it has a certain effect in reducing pain, but as you continue to take morphine over multiple days, what happens is it loses its effectiveness in reducing pain. And this is problematic, because what happens if you're in pain or you like the pleasurable effects of morphine, what are you going to do if you continue to take the drug and you want to get those same effects? What was one option that you could do? You'll increase the dose. And so as that continues on, you're going to continue to increase the dose, and that cycle continues. Now, if you continue taking the drug in the same environment, then what happens if you go into a brand new environment? You take away those environmental cues. In that situation, you'll be giving the same dose of morphine. It's much higher than you were ever able to tolerate the first time, but now you don't have the body being prepared for that. And what we see is that you'll tend to overdose. So this is exactly what Shep Siegel, a Canadian neuroscience researcher, was interested in. And he kind of suggested this idea that classical conditioning may be important for the development of tolerance to certain drugs, and important for different aspects of drug tolerance, such as overdosing observed in heroin addicts. He got this because he did some ride-alongs. It's kind of a neat insight to some of the ways that we actually do science. Shep Siegel was interested in drug addiction, and he got some reports that oftentimes people overdosing from heroin would be left there, discovered on the scene where they'd overdose, and they would have only injected a fraction of what they normally inject, and they would actually still have the syringe in their arm with part of the heroin still in the syringe. And after interviewing some of their people they were with, they said, yeah, this person had always injected this amount of heroin, and there hadn't been any problems. So in this situation, he interviewed and he found that some of these people were injecting for the first time in a place they'd never injected before. It was a brand new place. But because they were used to injecting a certain amount, they had developed tolerance, and they'd upped that dose, now their body wasn't prepared. They didn't have the conditioned stimuli available to prepare the body for this much higher dose of morphine or heroin that they were taking. So he saw this occurring in individuals, people, but he wanted to study it. He wanted to investigate this and demonstrate that, man, classical conditioning might be an important factor here. And so he wanted to develop a procedure to do this with rats. And so what he developed was a way to assess pain in rats that wouldn't cause any kind of wouldn't cause any permanent damage. It would just be uncomfortable. He would then give them morphine to see what it would do to that response, and then see what happens if he changes context. How would they do? How would they respond? And so we're going to talk about a series of studies that he did, experiments. And I'm going to go slowly through this so that you get a good idea of how the experiment was set up, what the results are, and what they supported, with the idea that I'm trying to make an argument, I'm trying to convince you that classical conditioning also plays a role in the development of drug tolerance, morphine tolerance. So in this study, he had several groups. Here, what we see are in this study, he had a couple of groups, and it was set up so that these animals received morphine and were assessed for their pain tolerance on day 1, day 2, day 3, and day 4. And basically what you can do is set up a room that is maybe dark and it's quiet, but maybe it smells like vanilla or lemon. And so that creates a context. And so you would take these rats into that room, inject them with morphine, and then put them on the hot plate and look at how did they respond. Now, a normal rat, or a rat that isn't on a morphine, once you put it on this plate, hot plate that he used, what would happen is the rat would pick up their paw and start licking it in 10 seconds, indicating that it's becoming uncomfortable. But if you give them morphine on that first time they go on the hot plate, what you'll see is that they'll take about 25 seconds before they lick their paws. As soon as they lick their paws, you take them off, take them in, let them recover, and then take them back to their home cage room. And what we see here for these two groups is that the group that doesn't receive saline, or doesn't receive morphine, they receive saline, they show a very consistent time to lick their paws across days. So they're not changing. So the saline hot plate group, these blue bar, dark blue bars here, show that they are really not changing their latency to lick their paws. Whereas the animals, the rats that received the morphine, we see that on day 1 they had a much longer latency to lick their paws, demonstrating that morphine is reducing their sensitivity to pain. So they're able to see a behavioral effect of morphine in terms of reducing their sensitivity to pain. But what we also notice is from day 1 to day 2, morphine isn't as effective as it was before. So here, from day 1 to day 2, we see that there's a reduction in morphine's effectiveness, that definition of tolerance. And by day 3, it's even less effective. Now, day 4, what we're going to do is these two groups will be tested again, where we'll see what happens when we inject them in the hot plate room with morphine or saline. Now, we have a third group I haven't told you about yet. This is group morphine cage. And we couldn't assess their sensitivity to pain while morphine because we wanted to test them, have them develop tolerance in an entirely different context. It's like those people that had been injecting maybe in their bedroom and upping that dose multiple times, and then one day they go out partying with their friends and they inject in a bathroom at a business, a bar. And so we wanted to be able to have them develop tolerance and then change the context on day 4 for them. They receive the identical dose of morphine as this morphine hot plate group does on day 1, on day 2, and day 3. We just are not able to assess their pain because we want them to be receiving the drug in a different context that then they're transferred to, and we can assess their sensitivity to pain on day 4. So we have 3 groups of rats. Two groups are being tested every day in this morphine hot plate room that's dark, that's quiet, maybe it smells like lemon on day 1, day 2, and day 3. And we see that the morphine group that's receiving the exact same dose on day 1, day 2, and day 3 is showing that definition of tolerance. The morphine is not as effective in reducing pain. The saline group is showing a very stable latency to lick their paws across days. They're getting saline injected in that hot plate room. And then we have another group of animals that on day 1 gets the same dose as this group did, but they just stay in their home cage. On day 2, they get the same dose of the drug on day 2 as the morphine hot plate group. And on day 3, they get the same dose, but we're not assessing their pain until day 3 when they go into a brand new context. So that context is new. They've never been there. So that means, based on our classical conditioning model, they are getting the conditioned stimulus, they're getting the unconditioned stimulus, the morphine, without the conditioned stimulus, the context. All right, so this group, morphine cage, is getting the unconditioned stimulus, the morphine, without the conditioned stimulus, the context. And so what we predict is that they should show that morphine now is effective. And that's exactly what Shep-Siegel observed, is that our group that received on that day 4, that had received morphine here on day 1, day 2, day 3, day 4, now they're showing the equivalent amount of Paulick latency as we see here for our saline-treated group. Now the morphine cage, they received the same dose on day 4 as they did on day 1, day 2, day 3, but they're just receiving the new context. And now they aren't as sensitive to pain as these 2 other groups. So morphine now is effective for this group. And the only difference between this morphine cage and the morphine hot group is that this group is receiving this morphine in the new context, demonstrating a potent evidence that where you receive the drug is really important. And if you change that location or the environment, and you still have that high dose for those people that have been upping that dose morphine, and you go into a new place and you inject with that same high dose, you can overdose very easily. So this was a nice translation from what Shep-Siegel observed on his ride-along with these calls for people that had overdosed from heroin, to coming into the lab and seeing whether environment was really an important factor. And this was an evidence, yes, where you receive those drugs has an impact, and that history. If you repeatedly administer a drug and you see the development of tolerance, and you change that tolerance to a new context, that tolerance goes away. Basically what you're doing is you're giving the unconditioned stimulus, the morphine, producing the unconditioned response, the analgesia, but you don't have the conditioned stimulus or the environment that will produce the compensatory response and eliminate or reduce the effects of that drug on the central nervous system. So this was one study. Another study we wanted to look at, this was designed to look at individuals where they just give them a timeout, and you then, the next study was designed based on an observation of an ad campaign that happened in England. What they found is, there are different drug campaigns, and they use media to promote not getting addicted to drugs. Well, when they introduced this drug campaign, what they found, the drug campaign was basically showing a lot of the paraphernalia, some of the stimuli associated with injecting and abusing heroin. And they found that people that had been abstaining from heroin, when they saw these signs, started to experience withdrawal symptoms. So you can imagine walking through a subway, seeing the sign that has all the paraphernalia associated with heroin abuse, and this person had been abstaining, they hadn't been abusing, they see the stimuli, the conditioned stimuli, and they don't have the heroin on board, the unconditioned stimulus, and now you get the conditioned response, which is compensatory in nature. It's trying to counteract the effects of morphine, and now you get these withdrawal symptoms. You're starting to feel as though you're agitated, you are you're irritated, you don't feel good, you start to feel pain, and you want to maybe go back and abuse or think of the drug as a way to eliminate these symptoms. Well, Shep-Siegel wanted to take that phenomenon that was observed in the world and bring it into the lab. So what he did is the same kind of thing. We have a very similar graph here, and now this is a completely within subjects group. So, and our graph is a little bit different than what you see here, where we're looking at change scores. So basically, above the line, around 100, means that you're increasing the latency to lick your paw, and then below the line means you're reducing your latency to lick paw. And so what we see here, when we administer morphine over 4 days, there's that gradual decrease in effectiveness of morphine to reduce sensitivity to pain. So we see this changing across here, our tolerance. Then what we did, or what Shep Siegel did, is he gave a 2-week timeout to kind of wash these rats, get the morphine out of the system. And then he came back and he did something that was very different. Instead of administering a drug or changing context, he took the rats back into the identical context and gave them saline. So he gave them saline again. So he gave them saline and injected them and assessed them for their sensitivity to pain. So after that 2-week timeout, he gave those same rats that had developed tolerance an injection of saline. And if you think about it, you're injecting saline, that should have no effect at all. But if classical conditioning is important or contributing to the tolerance that we see in drug addiction, and we're giving the conditioned stimuli, which produce this compensatory response, in the absence of the US, which produces the UR, we might see something that's in opposition. And that's what Shep Siegel observed. That now, when you administer saline, just simple saline, these animals are licking their paws much faster than normal. They were licking their paws much faster. So they had the conditioned stimuli that produced this compensatory response that was trying to negate, trying to eliminate the effects of the drug, but the drug isn't there. And essentially seeing that these animals are hypersensitive to pain. One of those features of withdrawal symptoms that were those people that had been exposed to that ad campaign showed that they became agitated, and they felt like they wanted to go and use the drugs again to remove those or eliminate those withdrawal symptoms. So this is further evidence that classical conditioning or learning can come in to influence the development of tolerance to drugs. So our next study I'll describe the study, the third experiment here, and I'll see whether you can come up with what you think, whether it's applied or not. Here we have 2 groups of animals, same kind of setup. Now, again, I want to point out the y-axis is set up so that if it's higher, that means there's a decreased sensitivity to pain. If it's lower, that means it's more like the regular sensitivity to pain. We have 2 groups of animals indicated here by the red and the green lines. And during trial 1, trial 2, and trial 3, we see that they're showing their typical reduced effectiveness of morphine across trials, and they're showing that they're now sensitive to pain, like normal conditions here. And then how the groups differ, the only way these 2 groups differ is that during a 2-week timeout period, one group, MPM, morphine, placebo, morphine, receive multiple placebo injections in the hot plate room. So they received an injection of saline in the hot plate room. They weren't assessed for their pain, they just got that drug, or the saline, administered in the hot plate room. So we're basically presenting the CS multiple times without the US. We're giving them the context, the paraphernalia, everything, multiple times without the US or the drug on board. So that's what we're doing. The morphine, rest morphine group, instead of being exposed to the context or the CS, those environmental cues, it just stayed, those rats just stayed in their home cage for those 2 weeks. With the morphine, placebo, morphine group, we're getting those daily injections of saline. Now, given what we know about drug effects so far, you really wouldn't think that there should be an effect. After that 2-week period, both groups get the same exact dose of morphine. They get the exact same dose of morphine. we would expect that they should both show tolerance. However, if learning or classical conditioning is coming into play, and we're repeatedly presenting the CS without the US, that's referred to as extinction, right? That's an example of where, with our dog, we continue to give, say, the can opener, but never giving food. The dog's going to eventually learn that that food is no longer coming with that sound. And what we'd expect, if it was classical conditioning and we have extinction, we should see a change in their group's responsiveness to morphine on that day 4, after that 2-week, or session 4, after that 2 weeks of placebo injections for this group and just resting in the home cage for this group. And that's exactly what we find, is that group that received those placebo injections show that now they're not as sensitive to pain, or morphine's more effective. So they're showing a decreased sensitivity to pain, where morphine is now effective, compared to this group that just stayed in their cage, and now they're just as sensitive to pain as we see during session 3. So just to review these experiments here, what we're doing in our first experiment, just to kind of go through this again to give you an idea, is here in this experiment we have 3 groups. We're looking at their sensitivity to pain. When we're up higher, there's no pain. Down here, there's pain. We see we give morphine. They're showing a much longer latency to lick their paws. They're not as sensitive to pain, but the effectiveness of morphine decreases across trials, where by trial 4, that group is not as sensitive to pain. The argument is that they are developing a conditioned association between the context and that drug, so that when this morphine cage group, well, they're never assessed for pain, but we switch them to a new context, and they don't have the CS, but they have the US, we see that they're showing that morphine is very effective, or they're showing a decreased sensitivity to pain. For the next study, we looked at, here is the development of tolerance. This is a change score here, showing that now they're taking much longer to lick their paws, to now they're taking the same time to lick their paws as they did prior to the drug administration. We give them a saline injection after a 2-week timeout period, where they never are back in that room. We give them saline. Now they're licking their paws much more quickly than they would normally, showing that maybe they're more sensitive to aversive stimuli. In our last study, what we do is one group gets repeated exposures. They get repeated exposures to that room. We're trying to extinguish that association between the CS and US, the context and the drug. And what we see here is when we come back and give them morphine on this 4th session, that morphine placebo morphine group, here they're showing us a decreased sensitivity to pain, where now morphine is effective, where we've weakened that association between the CS and the US. So the question is, how can this last study be applied to humans? How can we apply this study to the treatment of drug addiction in humans? What you can do is pause the lecture, think about it for a little bit, because I'm going to give you the answer to this question. So see if you can't figure it out, talk with people, see what you come up with, but here's the answer. This can be applied by humans by looking at methadone treatment. First, methadone is nice because it's a different route of administration. People orally ingest this. So they aren't going to have that immediate peak in blood alcohol or blood concentration of morphine, and it will be sufficient to keep the withdrawal symptoms at bay. But people on methadone go back into their environment, and they can extinguish some of those associations between the drug and the environment, the context. So maintaining them on that methadone allows them to not have withdrawal symptoms. It also allows them to break some of those context and drug associations, and then gradually over time tapering them on a lower and lower dose of methadone. so that then they can eventually be off, so that when they're completely off, they return back to that environment. They see those cues, they aren't going to abuse again, begin having some of those withdrawal symptoms because you have the CS, environmental cues, triggering the CR or some of those withdrawal symptoms. Now, I have to tell you that methadone treatment isn't 100% effective in treating this, but it does help. It is a viable option for some folks. And understanding that classical conditioning does contribute to the tolerance that develops with drugs, helps you develop better treatments. This work was done in the 70s, 1975, and has been followed up, and now people are trying to understand what parts of the brain are contributing to this learning, and targeting that we can develop maybe better treatments to allow us to eliminate that association or try to control that process more effectively. So we concluded our last chapter for exam 3. This is again chapter 6 on drugs and behavior. So what you want to do is for each chapters 4, 5, and 6, you want to go through, review the lectures, attempt the lecture quizzes, and attempt the practice exams. And once you feel like you really have a good idea, make sure you're taking the notes, review your notes, recopy your notes, and take notes from the textbook. You then will be ready to take exam 2 that's available. Now remember, exam 2 is going to be covering chapter 4, 5, and 6. So keep that in mind, and I look forward to talking to you next time, and we'll get to talk about development of the central nervous system and behavior. Good luck on exam 2. Talk to you soon. Bye.